Well, let me ask you actually, doctor,
Yes.
when you have a patient that comes in and they've suffered a traumatic brain injury, is there a time where you have to refer them out maybe to another specialist for some of their signs or symptoms?
Yeah, that's a great question. So, I mean, in every disease process, and more specifically in TBI, I really approach the patient as an individual person, right? We know TBI is a very complex disease that has long-term consequences, sometimes permanent, like I mentioned. So we try to do individual approach for each patient. So it's hard to do an algorithm, but I'm going to mention a few things that we always do in general. So we try to focus a lot on the physical symptoms the patient is having, right? We want to treat their symptoms. So if the patient has headaches or pain or neck pain or occipital neuralgia or migrainous type of post-concussive pain, we try to approach those symptoms and try to treat them. A lot of patients have sleep problems, right? So we always try to maintain a sleep hygiene. I always tell them to keep a diary, try to understand patterns and triggers of their pain. How is that affecting their sleep-awake cycle? I explain how to keep a regular sleep schedule and reduce disruptions. I tell them to take breaks during the day. Sometimes they get too much fogginess, cognitive disruption. They want to go back to work. So I always give them that general advice. Try to simplify tasks every time there's possible. Try to conserve energy during the day. We talk always about how to plan a proper nutrition, any stress management and relaxation techniques that they have. So all these things as a general type of picture. And then of course, we rely on imaging for prognosis. We did talk about that. If I feel that, you know, it's a severe case with a heavy cognitive problem, either with a planning or executive function or having problems with delayed recall, I work with my colleagues, the neuropsychologists, to help me do a more comprehensive assessment. And in case we need to do any directed pharmacological therapy or any non-pharmacological therapy like TMS, I rely on them for a diagnosis and a follow-up. Somebody I think mentioned vertigo. We do a lot of vestibular testing. It's very, very common to have vertigo as a post-concussive symptom. So testing the vestibular-ocular motor screening or vestibular-ocular reflexes is very important. We test for smooth pursuit, we test for saccades, convergence, vestibular-ocular reflexes. We test that in the office ourselves with electron nystagmography. But if we need anything advanced, of course, we rely on ENT for any audiogram or any other advanced therapies that we need to.
Now, when you have, there's a lot of different symptoms that somebody can have following a traumatic brain injury, and you've talked about a number of those, but what if somebody just has, they don't have headaches, they don't have any somatic complaints, but their primary issue is one that's emotional, where they're saying, hey, look, I'm really depressed after this, or they have anxiety or maybe mood irritability. Are those symptoms that are consistent? Let's say they have no other symptoms, but those are the type of symptoms they have following a traumatic brain injury. Are those consistent with the traumatic brain injury?
Yeah, so that's a great question, Tom. So as I said, the diagnosis is clinical and we need to do the diagnosis right away at at the scene of the accident. So the symptoms can vary from physical complaints, cognitive and psychological, right? Or psychosocial, as I mentioned initially. Every case is different, so I don't want to generalize and say it could be or it cannot be. I will need to assess the patient per se. But yeah, there's patients that predominantly, a lot of their symptoms are psychosocial or psychological per se, right? So I do rely a lot on my neurocognitive and neuropsychological colleagues for that. But depression is very common, anger outbursts, irritability, personality changes, anxiety, sleep-awake cycle disruptions. All these are part of the post-concussive phenomenon, and we can see it on TBI. And to be honest, this could be the most disabling symptoms for the patients. So we want to do, the general things that I mentioned, keep a diary, stress management. If we need to do behavioral therapy, we do that. We actually, in my practice now, are preparing, we have a protocol for do transmagnetic stimulation for patients with a lot of depression and TBI. A lot of them have some cognitive issues, mostly in the frontal lobes. So some executive dysfunction, problems planning, They have problems with verbal fluency, generating information or bringing names or things out. They can have problems with attentional processing or even memory impairments.
Now, there are other specialists that you talked about, and one thing that us attorneys hear about is, neuropsychologists or neuropsychiatrists. As a neurologist, you're different than both of those types of doctors. So, just from treating patients, when would it be appropriate, or when do you see fit? Hey, this is a patient that may benefit from some neuropsychological testing or a visit with a neuropsychiatrist to help treat their symptoms and or get a better idea of their prognosis?
Yeah, that's a great question. So you mentioned the two keys. So one is proper diagnosis and one is prognosis, right? And how to guide treatment, personalized treatment. So I use them a lot in cases where patient has a lot of symptoms, but there's also history of depression, and the emotional component gets kind of confusing with the cognitive changes. So I do need more objective type of ancillary testing. And the neurocognitive, it's a very tedious, I would say robust type of testing. So I rely on them to help me distinguish between the two characteristics. And it also helps us a lot for prognosis, right? So their recommendation and tell us, listen, we did this kind of testing, we did this, and we think this area of the brain or this, sphere, it's more affected. Then we can even talk to the patient, and that's when we try different pharmacological agents, right? These patients that the cognitive symptoms persist above 3 months, above 6 months, they want to go back to work, they're disabled, and what to do. So we talk about pharmacological therapy, right? There's no one to go, but there's for different symptoms of different people, we try different things. I've tried stimulants, Ritalin is probably one of the most studied. We try dopaminergic agents, we try serotoninergic agents, sometimes acetylcholine receptor blockage. So different patients, we try to do a personalized treatment. And as I said, we're using more and more transmagnetic stimulation for treatment.
Thank you. As an attorney, one of the things that we see a lot of in the literature, and I'm a plaintiff's lawyer, so I represent only people that have been hurt, is when I have a client that has had a brain injury, a concussion, mild traumatic brain injury by definition, and there's no objective imaging, Glasgow Coma Scale's 15. What I hear most of the time, the pushback I get is, hey, this is something that should have resolved in 3 months or less. That's what I hear. And then I see the literature out there that there's this term called the miserable minority. So there's a certain percentage, maybe 15 to 30% of patients that have suffered what we would categorize in some arenas as a mild traumatic brain injury. Well, they're not so fortunate. They continue to have symptoms that persist and may even have long-term disability. And just in your clinical experience, and the literature that you've reviewed, are there any factors or conditions that make it more likely for someone to potentially have long-term effects or fall into what we call the miserable minority?
That's a great point, Tom. So like everything we have in epidemiology, right, in big prospective studies, we need to take it with a grain of salt, because we said at the beginning, every patient is different, and the patient I have in front of mine, it's completely different. I'm going to give them a personalized treatment. So we talked about certain prognostic factors at the beginning. So we have factors that we cannot even modify, right? Those are the biological factors, and we don't even understand them, right? There's so much genetic involvement in predisposing to this minority that you are telling me about, right? There's studies with ApoE4. There's different genes related to this. We talked about sex, we talked about marital status, environmental factors. We talked about comorbidities, right? If a patient has any other neurodegenerative process, they're gonna do really bad after a TBI, right? So we cannot put them and compare them with a healthy young male, right? Other comorbidities like hypertension, diabetes, it increases and accelerates the neurodegeneration in the brain, right? Remember that in TBI, in pathophysiology, there's two big events. There's the big event initially, right, where you can have shear injury and the concussion, coup, counter coup. And there's the second event that is the cascade, the neuroinflammation that comes after. that's when the blood-brain barrier gets disrupted, this cerebral edema, and this could last weeks, months, years, right? And that's when the axon actually dies, and there could be deposits of tau or phosphorylated tau or beta amyloid in the brain. And that's why the brain, 10 years down the line can have an accelerated dementia process.
Thank you for that. Now we're close to 3 o'clock. Do we have until 3, or do we have a little bit later than that, Charlie? Or just wanted to check in time wise, so we're not, so we have some time for any Q&A and time for any some legal stuff too.
Yeah, we scheduled till 3:15, Tom. So.
Okay, great. Because I do have some further questions for Dr. Eskenazi. So we have clients that suffer traumatic brain injuries. And then one thing we really want to know, and we touched on that just a moment ago, is what are the sort of long-term effects or consequences of a traumatic brain injury? And even if you have a client or a patient who seems to have resolved and maybe they don't have symptoms anymore, maybe they do, it could be either of them. There's talk and literature out there that suggests there's a potential for an increase early onset of dementia or Alzheimer's. And I'm wondering, just what's your understanding of the literature out there in terms of there being sort of a long-term consequence or an increased risk for someone that suffered a traumatic brain injury and either early onset of dementia or getting it?
So yeah, so that basically represents the second cascade of events I mentioned in TBI, right? So every time there's blood-brain disruption, and there could be, aggregates of these proteins in the neurons, and there could be programmed death of the neurons, then basically, and then you have an MRI, there's volumetric changes, brain, white matter disease problems. So clearly, yes, it can accelerate any dementia process. There's plenty of papers. There's one that I like. It was Vincent et al. In 2014, I believe, that basically just one single event of TBI can accelerate any cognitive decline 10 or more years after the injury. So again, every patient is different. Every patient has different biomarkers and different characteristics, but definitely it can increase the risk for dementia.
And you touched on some things, but clinically, when you see a patient that has had a traumatic brain injury, what are some other injuries that you see that tend to happen in conjunction with the brain injury, or may happen in conjunction with the brain injury? I mean, are there other things that we should be looking out for our patients, clients, to make sure that we're addressing everything and not missing anything?
Well, that's a great question. I mean, that's why it's a multidisciplinary approach. Typically, when there's a TBI and there's a huge impact, right, and there's a rotational component to it, a lot of the patients have polytraumas, right? You know this better than me. I'm not an expert in anything below the neck, but you can have all types of fractures, joints, spine. So patients have multiple complaints that are not only neurological, right? And it's not only the TBI part. But we did mention in TBI, we talked about neuropsychology, we talked about ENT, tinnitus can be a big one, hearing loss. So we do all those type of things. I work with ophthalmologists or neuro-ophthalmologists. They can have visual problems. Sometimes there's dysregulation, and there could be endocrinology abnormalities. So an endocrine doctor would be indicated to see the patient too. So definitely it's multidisciplinary. I work with neurosurgeons, spine doctors, orthopedics, hand in hand, pain doctors. Epidural sometimes are great for the patients. Whiplash injuries, they can get occipital neuralgia and different types of pains. So yeah.
And if you have, say, the occipital neuralgia, how would somebody treat that? Or how would you treat that?
So we actually treat that in the practice a lot. So occipital neuralgia per se, or triggering a big headache, we can block the greater occipital nerve, and we can block the lesser occipital nerve. We can also do some trigger point injections in the neck. So that helps a lot, not only alleviate the pain, but helps the patient, have a restful sleep, be less anxious. So all this snowball that creates on the second cascade of TBI, that's what we try to act right away.
Is that something that you perform yourself, like an occipital block?
I do. We do it in the office, yeah.
Are there other treatments that you perform like that? Other injection type treatments or blocks other than the ones for occipital neuralgia?
No, I mean, I basically do everything that is indicated neurologically. So I do the occipital nerve blocks. I can do some trigger point injections. And we do the transmagnetic stimulation as a non-pharmacological treatment for TBI and depression.
Thank you for that. There's one thing that I always deal with as a plaintiff's trial lawyer, and it's really the credibility of the patient client. And there are, if we were to kind of look at it as a spectrum, there's two sides to it. And sometimes you have a client or patient that really underplays or downplays the severity of their injury, right? You might have the tough person syndrome, right? Where they may have lost consciousness, but they're fine because they're not blacked out and lying on the floor. And, you know, they're not really forthcoming with their injuries. And then on the other side of the spectrum, you could have someone that's coming to you and they walk in your office and they're saying they got 10 out of 10 pain. And you're like, you just walked in the office and you're not screaming bloody murder and you're telling me you're 10 out of 10 pain. How do you deal with both sides? I mean, I guess you could start with one or the other, but when you have a patient who you know may not be telling you the full story, how do you make sure to get the full story? And then if you have a patient that seems to be really, you know, it in some ways it looks like it's exaggerating, but it may not be. How do you deal with that as a clinician?
So that's a great question. And the short answer I'll try to explain would be that's your clinical expertise, right? 15, 16 years of training, seeing multiple patients per day, every day of my life. But basically, yeah, patients who downplay symptoms, you need to see what's the underlying problem there, right? It could be an emotional component that is not letting you talk about it, right? So we can always talk to family, right? They always come with somebody, see how is the patient acting at home, right? What's the behavioral, what's going on, what's the mood? So usually the partner is the best person to help us with that. And then every time, you know, when you see a patient for the first time, you create this relationship with your patient, right? This doctor-patient confidentiality and the relationship. So that rapport with the patient is very important, I think, in the management of TBI. And that's why I love doing plaintiff, as you said, because I love treating my patients, right? I can be an expert, I can go to trial, but I love treating my patients. I will treat them forever if they need to. So that's very important. And we always rely on our colleagues too. If I need a neuropsychological evaluation to help me, definitely, you know, 2 different eyes, 2 different practices, why not?
Now, one thing I want to just touch on for a minute is this, it's a term that I use and I think is important just as a lawyer representing people, is clinical correlation, and taking the history, the examination, the symptoms that you're seeing and whatever imaging exists and trying to see if there is a correlation. How do you go about doing that? Or just, I guess maybe the better thing is, can you just explain that to us a little bit, the importance of having a clinical correlation and how that factors in to your diagnosis, your prognosis, and treatment?
Well, I would say the most important part in clinical correlation is if the patient is telling you, I'm weak on my right side, when you examine the patient, you want to objectively find some weakness, right? So I would say the first clinical correlation is whatever you get in your anamnesis, right? In your history, the subjective component, you want to find it objectively, right? And cognitively is the same, right? We do different techniques to analyze the cognitive of the cognition of the patient. So I would say that will be the most important. After that, you have all these ancillary testing that we talked about. They're very important, but you want to correlate.
Got it. All right. Well, what I want to do is I want to kind of touch a little bit on some of the legal aspects of all of this that we talked about, and appreciate you answering all those questions thoroughly, Dr. Eskenazi. And if I say anything in the next, 5-10 minutes that's totally off base, I hope one of you will jump in and correct me, so that, I'm not making a fool out of myself. But one of the things I heard from both of you is just how important it is early on, the initial trauma, what happened there. And as we learned, a lot of times, virtually always when a patient goes to the emergency room, they're not going to have access to an MRI for their brain, or they're not going to have access to a 3T MRI or DTI. What they're going to get at best is a CT. And so for people that are representing patients that have suffered traumatic brain injuries, you really have to look beyond the emergency room records. And something that I found to be really effective is talking to the people at the scene, meaning witnesses, meaning the EMT that was there, ambulance, fire department, police. And I've had a number of cases where the patient themselves or the client is saying, look, I didn't have a loss of consciousness, or I don't know if I did. And then you have a negative CT and negative MRI. But then you come to find out that there was a witness on the scene. And the witness will say, I approached, say it was a bad car wreck. And the witness comes in and says, I was there and I was trying to get this person's attention, your client. I was saying, hello, hello, and they weren't responding to me. And that went on for several minutes. And then they weren't, they seemed disoriented for the next 15, 20 minutes, and they were shaken up. So what you've done is, even though you don't have a TBI, you don't have a loss of consciousness or an altered consciousness documented in the emergency room records, or even structural injuries documented in the imaging, you're able to create a loss of consciousness or altered consciousness and show that it has happened just by the witness's testimony. And that's been very powerful, because it suggests that you have somebody who's had a Glasgow Coma scale of less than 15. So to the attorneys out there, I highly recommend that if you have a police report that has witnesses in it, that you contact those witnesses immediately, get the police report right away, find out who those people are and interview them and talk to them as to what they've seen. I mean, you can have another case, a really random case where an elderly woman went to go get a hot dog at a food truck, and the metal awning of the food truck fell on her head. And the food truck owner denied that this even happened. But fortunately, there was an eyewitness there who gave that information and documented what happened. And the eyewitness told us how this woman was knocked out. And so we had a very strong case for that. So your cases may seem, you may be looking at it and say, do I even have a traumatic brain injury here? But you really got to do the digging and do the investigation, and you may have a very viable claim. And that person may end up, even though it seemed like nothing happened, they end up having severe problems long term. So it's something that's really important to consider. Also, if you don't have all of the things, like you have someone who has had a traumatic brain injury and their memory's fine, or their cognition's fine, or maybe they're doing even better at work, who knows? But they have one symptom, and maybe that's headaches or migraines. Those are legit TBI symptoms, right? If a person just has one symptom, would that be fair characterization, Dr. Eskenazi, Dr. Watanabe?
Yes.
Yes.
Tom, you're doing well. We're reading the questions, I think.
So, don't shy away from a case just because you don't have this whole slew of issues with the client, because headaches can be extremely debilitating for somebody. And anybody that knows that's had a migraine, I mean, if you have a constant pounding, those cases have serious value. So take them seriously early on. And just kind of overall, one way that we really lose credibility in our cases is when someone like Dr. Eskenazi or anybody recommends treatment. And so if you send your client to a doctor to get, evaluated, and there's a list at the very end of the things that they need to do them. Because if you don't, you're going to end up, hurting your case, because here the doctor has outlined all of the things that they should be doing. So you have to be proactive and make sure that that gets done, because a lack of continuity in the treatment is going to make you open to, hey, maybe this client doesn't really have this issue. Or if they do really have this issue, you failed to mitigate the damages by not getting the treatment that you need. So the recommendations that are outlined aren't there just for show and tell. They're there really to make sure that your client gets those treatments and that you follow through with those modalities. So definitely make sure to follow up on that. One thing about TBIs is there's something called somatoform disorder, right? And it's in the DSM-5 or whatever the updated version is. I think do we have a DSM-6 now? Or is it's still DSM-5, right? So somatoform is a defense that's brought up a lot, and it's to try to attack your client as if they're lying or malingering or exaggerating, but it is a real disorder. It is real, and it's debilitating. And if you have a case where somebody has true somatoform disorder, that is a real injury. And I think you need to own that. Don't shy away from it, but own it and make that your case. And now they have it, and it's a diagnosable condition, and it's something that I think you should own. In terms of just overall experts, I think it's important when you have a traumatic brain injury to have a neurologist. That's sort of, in a lot of ways, the quarterback of working up the case properly so that you could support the injury. And a neurologist is someone that I have in almost all of my traumatic brain injury case. And of course, an imaging expert like Dr. Watanabe. So I make sure that if it's a brain injury case, you definitely want a neuroradiologist, not just a radiologist. And radiologists are great for orthopedic injuries, but if you're going to talk about the brain and spine in particularly, then you want someone that is board certified in neuroradiology. So 2 doctors that I virtually have in all of my traumatic brain injury cases are a neuroradiologist and a neurologist. Now, sometimes, as we talked about, a neuropsychologist comes into play, and that can be really helpful to understand how the injury is progressing, how, or what prognosis you have for the patient. So I definitely consult with neuropsychologists and use them to help show what injuries my client has. And there are a host of other injuries or other experts as well that I think are important. And whether you have a life care plan, say there's going to be future treatment needed, if you have a life care planner, I always make sure that the client actually sees the life care planner that they meet. And maybe nowadays it might be a little more difficult, but have them at least meet over Zoom. And same with a vocational rehabilitative expert, because if somebody has a traumatic brain injury, however you categorize it, mild, complicated, moderate, or severe, if they do have long-term disabilities, that's going to affect their ability to earn. It's going to affect their earning capacity. So those are all things to keep in mind. I know that was a quick little just something, but I want to leave you with a couple top points to just keep in mind when you're helping out your clients and the doctors that you need to get involved. I want to see if we have any questions here that we just didn't get to. Let me see here. So let's see.
There was one question that I answered on the chat.
Yeah, did you want to expound on that, Dr. Watanabe?
Yeah, one of the questions was about imaging patients who have dental work. And if patients have simple fillings, it's usually not a problem, although we can often see them. The one piece of dental work that's really a problem are people with braces. So patient with braces, we can scan them, but the image quality is very, very limited. Another question that came up was about when to do SWI or DTI. As I showed in one of my slides, that on MRI, hemorrhages are a little bit delayed. That you can see a hemorrhage acutely on a CAT scan almost immediately, but with MRI, the ideal peak for seeing hemorrhage on MRI is in that 3 to 5 day window. But with SWI, you can see chronic microhemorrhages that can be there really for life. Once the hemorrhage turns into something called hemosiderin, that's usually there for a very, very long time. The DTI, I think that subacute window is ideal. FA values tend to still be dropping from 0 days to 1 week, but after 1 week to 2 weeks, there may be a trough, and certainly a patient could be scanned up to 8 months in the literature and still show FA changes.
There was one question I saw here where you have someone was asking what types of scans or imaging or tests would be helpful or needed for somebody that suffered a traumatic brain injury. They're a 26-year-old male that was in a violent rollover collision, documented head injury, they had a loss of consciousness for 1 to 2 minutes. and apparently they've had a total loss of testosterone production. And I haven't heard that before, but I don't know if either of you doctors have heard of that before, and if so, what kind of imaging or tests would be beneficial in trying to document any kind of causal relationship there?
Well, Dr. Eskenazi can also add to this, but I have seen literature that testosterone levels can drop quite a bit in a traumatic brain injury, as well as other pituitary hormones like growth hormone. So there is no problem in doing an MRI brain and pituitary MRI. There is a condition called pituitary apoplexy, where patients can actually hemorrhage into their pituitary gland and have almost a complete washout of their pituitary hormones. It can be a very devastating and serious disease. Happy for Dr. Eskenazi to also comment about the testosterone drop that can be seen with TBI.
Yeah, so what you answered is actually perfect. So I've seen many cases with hypopituitarism or pan-hypopituitarism. Just specifically only testosterone, I haven't seen a case. Also, low testosterone is very prevalent. So I don't know if we can actually make causation directly, but it could be. And imaging-wise, yeah, an MRI dedicated to the pituitary would suffice. Probably an endocrinology visit and test the other panel of hormones from the pituitary.
I love this question because I see this all the time with spine injuries and MRIs and disc herniations, but can you determine the age of the brain injury to confirm that the brain injury was something new or old? Are there sort of signs or clues when looking at the imaging, or can you even do it by looking at the imaging alone?
That's really tough. I mean, we know with spine that often we cannot give a date of when the disc herniation occurred unless there are some really specific findings that sometimes we can see with acute herniations. Obviously, with the focal TBI, where you have a epidural hemorrhage or contusion, that's very easy to stage. Staging white matter fiber destruction is very difficult unless you do see the signs of the hemorrhage or the edema on the diffusion weighted imaging. So when you have a drop in the FA values in the brain, without having a baseline or a timeline, it would be really difficult to do a forensic analysis of when the injury actually occurred.
That's why you need the clinical correlation.
Yeah, it's great when you have a good charting, that's for sure. That's a very important thing.
I know you talked a lot about this, but we want to clarify a little bit. But someone asked here, is the DTI MRI or the DTI imaging different than a 3T MRI? And just to clarify, yes, and why?
So the 3T MRI is just a type of MRI scanner that's called ultra high field scanner. So that's actually the type of machine. And so when I recommend doing the 3T MRI, I'm recommending that the MRI scanner that you use be at that strength, which is the 3 Tesla strength. The DTI scan is a type of MRI study that can be performed on different magnets. The DTI scan is best done on the ultra high field 3 Tesla MRI. It can be done at 1.5 Tesla MRI scanner and cannot be done on the less strong magnets. So 3T designates the type of MRI scanner, and DTI designates the type of MRI exam that is sometimes performed for brain injuries.
So there's a couple more questions I know, and I thank you to both of the doctors for your time, and I won't take up too much. I just wanted to get to a couple more here. How long will volumetric findings take to show up on the scan after a trauma? 3 months, 6 months, what are we looking at?
Wow, oh, it's a great question. I actually have seen some examples where it can be seen quite rapidly, although in those cases, those are brains that were probably swollen from edema, and then the edema resolved. So there is literature with a timeline that shows atrophy in the brain after an accident in several patients. And I would say it occurs over months to years rather than days, but it has been shown that this does occur to a statistical level of significance compared to control people who haven't had brain injuries.
And we have, there's someone who has a case where they have a 3 to 4 millimeter posterior frontal white matter lesion that was detected on an MRI, but a contemporaneous DTI shows no abnormalities. And I know we touched on this briefly, but is that common where you'll see a lesion on an MRI but not the DTI?
If it's a solitary lesion, then it's hard to be able to say for sure that was from the trauma, because that is what sometimes we call the UBO, or nonspecific. And sometimes you'll see those white matter lesions in patients from other causes. But if the patient's under age 60 and doesn't have a lot of medical problems or doesn't have migraine disorders, then I would say it would kind of make it more suspicious that it could be from trauma. But certainly not every person who has had a concussion is going to have changes on their DTI scan, simply because it depends on the timing of the exam and just also whether the area of injury is so small that perhaps it can't be reliably detected on even the DTI scan. So it's not infallible.
Oh, is there a best protocol or a protocol for when to get imaging where you have somebody who suffered an injury from drowning, where there's been a loss of oxygen to the brain, or maybe it could have been carbon monoxide poisoning, and the person's having memory issues still, or headaches, or a combination of other symptoms? But when would it be appropriate clinically for someone to get imaging to make that determination?
Well, in the setting of carbon monoxide, doing it as close to the event is extremely helpful, because that's where you will see the changes on diffusion weighted imaging. After time, those changes disappear, and then you may just get cavities or little holes in the brain where the damage has occurred. So that's an interesting question, but I would say getting it done as close as possible to the time of injury, because basically that's a form of what we call anoxia, or anoxic injury that can show up on diffusion weighted imaging, but only in that very acute, hyperacute phase.
Okay, great. All right, we went a little bit over. I know there's some questions that haven't been answered. We'll do our best to take those questions that haven't been answered, and we can send out email answers. Would that be something we can do, Dr. Watanabe?
Sure, we can put something together.
All right, so what we'll do is, for the questions that haven't been answered, we'll try to just compile a list where we could send that out, and some of it was covered. One of the things people wanted to know is if they can have access to your PowerPoint. Is that something that'll be made available?
Okay, yeah, we can have Charlie can help assist in that preparation.
Okay, well, great. Look, I want to thank everyone for showing up. Thank you for the questions, especially thank you, Dr. Eskenazi and Dr. Watanabe. I know how busy both of you are, so I really appreciate taking your time to educate all of us on these issues. And again, thank you to all that participated to learn some more. So keep learning, because that's the way to get better at doing what we do. Thank you, folks.
Thanks for moderating. Appreciate
Thank you,
everything.
Tom. Thank you, Charlie.
Pleasure.
Bye, doctor.
Bye.
Stay healthy, stay safe.